welcome to the Headache Doctor Podcast, where it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication, allowing you to thrive in everything you do. Hello and welcome to the Headache Doctor Podcast, where, as always, it's our mission to educate and empower everyone out there with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we're going to talk about something that really bothers me in our healthcare system that I wish was changed. And the problem is that when you go see your healthcare provider, your primary care doctor, your neurologist, they will take an image of your neck, and that's the way that they're going to use, that's the tool they're going to use to evaluate your neck, whether that's an MRI or an X-ray. And if that MRI or X-ray shows you something, a wear and tear, degeneration, herniated disc, spinal stenosis, things like that, they're going to then start the conversation of injections or potentially surgery, spinal fusions, things like that. And so what we want to do is reframe your thinking about that process. If you have been told that your neck is really worn down, where did all this wear and tear come from? Your neck needs to be fixed if you're going to get rid of these headaches. If you've been told that, and that's led you down this thought process of thinking, okay, now I need surgery in order to correct these things, otherwise I'm not going to get out of these headaches or migraines, we're going to try to reframe the way we think about this. Now, of course, there are scenarios where spinal surgeries and potentially even injections are warranted and needed. Okay, so I'm speaking to thousands of people on this podcast, and the intent is for you guys to feel empowered, to have the education, to know what's in my head, and to know what I think about when someone comes to me with a neck issue, so that you can then make your own decisions within your own healthcare journey. And if you can do that and feel empowered to say, hey, maybe there is a conservative measure out there, so I don't have to feel like I'm trapped into getting the next set of injections or the surgery that's upcoming, that's the mission we're on, is to allow you to feel freedom into how you live your life and getting your health back. So what we're going to do is we're going to talk about the anatomy of the neck, how the neck moves, the biomechanics of the neck, and that's going to lead us right into this conversation and a better understanding of why people have these signs of wear and tear in their neck. How do you get to this point of having degenerative disc disease, wear and tear through the mid portion of your neck, stenosis, things like that? And then from there, we're going to hit on some of the major sort of procedures or processes that are out there on the medical side of things, and potentially some of the benefits there, but also some of the things that you should be aware about going into those, and then we're going to sum it all up. So to start, and by the way, if you're watching this on YouTube, we are revamping the visual component of this podcast, which I'm really excited about. So we want to up our YouTube game. If you've been a YouTube follower, thank you so much. I feel like the product, as far as visually on YouTube, it's not been bad, but we can really up our game. And so we're gonna have guests come into the new studio setup, and it's gonna be visually much more appealing. So if you're someone that listens to the podcast and have wanted to watch on YouTube, stay tuned for that. Of course, you can always go over to our page, the Headache Doctor Podcast on YouTube, and like and subscribe to the channel, so that you can get the video portion of it as well. And it's not completely done, so I have it sort of I have it set up so that we can have video for this podcast, but it'll look even better in the future. But anyways, back to the topic at hand. All right, so the idea, and this is generally what happens when people start to have headaches, or they'll go to their provider and they'll say, I think it's my neck. I think I have a neck problem. And the provider will get an X-ray or an MRI, okay? An X-ray is usually a little bit less costly and easier access. So an X-ray might be first line, and then an MRI, depending on the provider, MRIs are more costly. They do show a lot more detail. And depending on what your symptoms are and what the provider's looking for, they will probably order an MRI. With migraine symptoms, MRIs are pretty commonly ordered, and the reason being is they want to look at your brain, at the head, at maybe some of the blood vessels or some of the soft tissue structures, rather than just the skeletal structure, which would just be like your neck. So X-ray would do a good job of showing us the bones, and then an MRI would show more of soft tissue, depending on the type of MRI that they're ordering. So that's very common. If you are wanting to know what's wrong with your neck, even in the general population, people think, well, I should have an image to see what's happening there. To really understand what's happening with my neck, I need an image, okay? So that's not completely false. That's not a false assumption altogether. But what we're going to talk about on this podcast is how there's a large chunk of information that we need that's not actually there when we're looking at an image. And that large chunk of information is how we move, all right? So as a physical therapist, my whole job and my whole life is getting people to move better, to understand how they move, and then restoring them and how they should function when they come into our practice, okay? So that's the first thing that in this whole cascade of events that then leads to potentially surgery down the road. And I'm not saying it will in your situation. I don't know your specific situation listening to this. This is just speaking out of experience from patients we've seen in the past. But generally, you get a still image. And what they'll see is somewhere between C3 and C6, or maybe C7, there will be wear and tear. There will be some signs of degeneration. The joint space will be narrowed, meaning there's a nice disc. A healthy disc should have a good amount of space in between the bones or the vertebrae in the neck. And if that has shrunk or narrowed, that would be degenerative disc disease. If that disc has a part of it that's sort of protruding into an area that it shouldn't necessarily be in, that's what we call a herniated disc or a bulging disc. And there's different stages of that. And that can cause problems, but it's also something that is relatively common. In the low back, at least, they did a study during the Rio Games, Olympic Games, took 100 Olympic athletes who had no pain, had no problem, they functioned at the highest level, and about half of them had degenerative changes to their spine. That would include things like herniated discs. So those things on images always have to be matched up with symptoms, okay? That's the first little nugget. We always have to match things with symptoms. Does it make sense with how this patient is presenting? We don't want to just take something like a herniated disc or degenerative disc disease and assume, okay, well, here's the problem, this has to be fixed, and here's the reason you have your headaches, okay? We can't assume that, and we'll go into that a little bit more later. There's other things like stenosis. So there's spinal stenosis, which would be more like or central stenosis, which is more in the central column. That's something to take a little bit more seriously. And then you have these little foramen, or these little openings where the nerve roots exit the spinal cord, and we can get stenosis there as well. And really what that means is there should be a hole of a certain size, and that has shrunk in this specific segment. So compared to the other segments of your neck, this one looks smaller, all right? So that can be due to things like arthritis in that area, all right? So what if we take a step back and, okay, so what is arthritis? Why would you have arthritis in that area? Why would you have a disc that is worn down or is herniated, all right? Why do we see these changes in the spine? Well, the spine is holding load. It's designed to hold up our head, to allow us to be upright. And so the way each vertebrae is designed is so that it prevents it. They sort of lock into place in a sense. The disc allows for healthy, good range of motion. And then there's ligaments that sort of hold the structure together. Now, if the vertebrae are just resting on each other, and what are called these facet joints, kind of on the back side of the spine, they're sort of firm barriers. The bones themselves sort of stop each other from going past a certain point, and that's helpful. But there's a lot of movement and available motion between all of these different vertebrae. And so in the neck, we have 7 different vertebrae. Each has a disc in between and some movement in between, and it's holding up our 10 to 12 pound head, okay? So there's weight applied to the spine, and over time, if that weight is managed well, we'll probably be looking at a relatively healthy spine, meaning not too many changes that would show that there's been added stress, more stress than the neck would have wanted. But if we see more of those wear and tear patterns, what it's going to tell us is that the weight on the neck has been increased in those segments to a point where it wasn't necessarily able to manage it, or the body was compensating in a way that added stress to those segments, okay? So we want to figure out the original problem. So how would you get to this point of seeing wear and tear in the mid portion of the neck? And instead of just saying, okay, well, now you have it, let's just remove it, or take away the pain by injecting a steroid or fusing it and removing the movement altogether. Now, again, there are scenarios where if someone's progressed far enough, where their neck is unstable, where they're having progressive numbness, weakness, or in their upper extremities and their arms, there are scenarios where those things make sense. But by and large, if we can get someone to start thinking differently in the appropriate treatment early on, we can prevent the body from getting to that stage. Okay, so why would wear and tear be increased in the mid portion of the neck? Now, this is fascinating. I love this element of just piecing things together, because there's so many people out there that have these neck issues, and they'll say like C4-5, C5-6. And when I say that, I'm just referring to the middle portion of the neck. C4 and C5, just the fourth vertebrae and the fifth vertebrae. C5-6, the fifth and the sixth. So where those interact, they'll reference those on images. So the radiologist will reference those segments as having wear and tear. So generally, it's the mid portion of the neck. So why would it be the mid portion of the neck? Well, the upper part of our neck is what takes on most of our rotation, and it helps us out with nodding, so extension and flexion of the head sitting on the first bone, and then it helps with side bending, all right? So the way the upper cervical spine is designed is such that it allows our head sitting on our neck to have this nice, smooth rotation, extension, flexion, side bending, all right? And with rotation in particular, we'll just use that for example, because most of our rotation, or at least half of our rotation, comes from the upper part of the neck. Let's say if you lose that rotation, you turn your head 90 degrees one way, and you've lost the 45 degrees that should be coming from C1 and C2, what happens is not that you just stop at 45 degrees, because our body's so good at compensating, and it knows that you should be able to rotate 90 degrees. What happens is you start utilizing the mid portion of the neck. So you still turn, maybe it's more like 80, 85 degrees of rotation, but you can still get there. It doesn't feel quite as good. It's kind of tight, and you're like, oh, that's not super comfortable, but you still do it. Now what's happening is that the mid portion of your neck is actually picking up the slack. Your body, your brain is asking these joints to do more work. And the same is true when we lose side bending and nodding, or flexion extension, in the upper part of the neck. The mid portion of our neck tends to take over. And so it's adding the level of stress to the mid portion of our neck when you are kind of none the wiser. You don't understand this. You're just going about your day, and you're turning your head, you're checking your blind spot, you're backing out of your driveway, you're looking up, you're looking down, you're watching TV on the couch, and your head's tipped to one side. You do all these things, or maybe you sleep on your stomach, whatever it may be. You're asking your neck to go to those end ranges of motion, when really there's a compensation pattern that's getting you there, which is adding some level of stress to the mid portion of the neck. Now, does that mean that you should never rotate your head all the way one way or the other if you have a neck problem? No. It just means that we should address the issue so that you can move the best you can, so that this doesn't go on for years and years or decades generally, okay? So for most people that have these neck problems, and this is a lot of people out there, I would almost venture, I don't know if I could say most people, but there are a lot of people with tight necks out there. Now what happens, it's not necessarily like okay, you have a tight neck and you have headaches, or you have a tight neck and you have neck pain. There's a lot of people that don't necessarily have daily symptoms. Their neck is just tight. The thing is, our bodies are able to compensate well enough where we get by. We don't have pain. It's not a big deal, okay? Now, if you have headaches and if you have neck pain, that definitely means your neck is saying, I'm tired of this. That's an alarm signal. That is your neck trying to get attention and saying something needs to change here. All right? Now, okay, if you're listening to this podcast, you very likely have neck problems, or at least neck pain, headaches, migraines, that sort of thing. You have those symptoms, you found this podcast, and you're like, all right, I got to figure out what to do. So if you've had the image and it says there's wear and tear to the mid portion of your neck, to summarize it, the upper part of the neck is not doing its job. The mid portion of your neck takes on the rest of that stress because you're still going about your day, asking your neck to do these movements. And it's not as if you should leave here feeling like, oh, I shouldn't turn my head to the right or to the left. It just means we should start taking steps to improve the amount of mobility in the upper part of the neck, take some tension off the mid portion of the neck so that your body doesn't have to continue compensating like this. And that pain signal, that alarm signal, can die down as well. All right, so there's the mechanics. There's a couple other things to consider. Now, if you have numbness, tingling down one arm or both arms, if you have pain that travels down in your shoulders or your arms, if you have weakness. Now, these are signs that the mid portion of your neck is actually potentially causing some of those symptoms, all right? Now, that's not always true. Like if you have numbness, tingling, and they've seen some wear and tear in the mid portion of your neck, it doesn't necessarily mean that your neck is the only thing to consider, all right? So what we want to do is look at a few different things. We want to look at nerve tension. So how well does that nerve actually move from the neck all the way down to your fingertips? Because if nerve tension is really high, that could cause numbness, tingling. It could cause pain, all right? So we need to consider that. We need to also consider things like thoracic outlet syndrome. That would be a condition where where your neck and your shoulder meet, there's there could be a buildup or a lack of available space for nerves and also blood vessels, causing numbness, tingling, weakness, or pain that travels down one side or the other. Now, the first rib could be elevated, which cuts off some of that space needed for those blood vessels. The neck could also be tight. There could be some muscle restrictions or muscle tension that impacts the available space there. So there's a lot of things mechanically that we can change and adapt that would allow someone to get out of that situation, okay? So just because you have numbness, tingling, or pain down the arm doesn't mean your neck is the only thing that would need to be addressed with like an injection or potential surgery. So when we think about the options that someone has, if you have neck pain or headaches or migraines, well, let me back up here just a second. Because if you have headaches or migraines and you have received a diagnosis of, all right, C4-5 or C5-6, you have degenerative disc disease or you have a herniated disc. If that has been connected to your head pain, I want to address that real quick because I hear that every now and then where someone has mid-neck problems and a provider will say, well, this could be where your migraines are coming from. And that's an interesting statement because as I've said before in this podcast, the referral pattern to the head, it comes from C0 to C2, C3 maybe. So it's really the upper part of the neck. So that if you go up to the top of your neck, just below the base of your skull, if you're watching me on YouTube here, press in that kind of soft spot just below the base of your skull. That's that sensitive area. That's C0 to C3. So basically the base of the skull, C1, C2, C3, that's that area that will send pain, shoot pain into the head or the face, okay? Now, I'm not saying that it could never happen where someone has a mid-neck problem that sends pain into the head. There are definitely like trigger points and knots and things lower and even into the shoulders that can send pain into the head. But for the most part, I think it would be a stretch in my mind for someone to come in with migraine symptoms and an image that shows some wear and tear to like C4-5 and to say, well, we need to address C4-5 in order for your migraines to go away. No, that's generally not what's happening. What's happening is the upper part of the neck, C1, C2, are not rotating, which there's a ton of tension and pain and sensitivity in that C1, C2 area, which is not seen on X-ray or MRI because it's a still image, meaning you're not looking at how much rotation C1 and C2 have when you get that MRI. It just shows the still picture. And so you see the problem with C4-5, which is just there because it's had to increase the amount of rotation or the amount of work that it's had to do just because C1 and 2 have lost its rotation. And then the pain itself, we can't assume is coming from C4-5 because it's very likely it's coming from C1 and C2. But since we haven't checked C1 and C2, we just move forward with the assumption that C4-5 needs to be worked on. And so we inject it and we do these crazy surgeries. And then the patient's in pain, maybe even more pain, because it didn't actually address the problem and it potentially made it worse. So how could it make it worse? All right, spinal fusions, those are a last, I mean, we want that to be the last case scenario. We don't want you to jump into this unless we are sure this is what you're needing. And generally, there's different conditions within the neck that would lead to sort of a precarious scenario where your spinal cord itself could be at risk. And so that's where definitely a spinal fusion to stabilize things would be warranted. But for the most part, if we want to take stress off of the mid portion of the neck, we need to get the upper part of the neck moving. And if we just fuse the mid part of the neck, we're basically just taking away that motion. And then the body's going to find it somewhere else. And so the segment above and below, it's commonly known that in these surgeries, eventually those take on added stress, and there's a chance that you're going to need a revision or additional surgery for those segments. And so it's sort of a short-term way of thinking, and I mean, if we see these things on imaging and we think, okay, well, here is something we can do, and if you feel like you've tried everything, meaning like in the Western medicine model, you've tried all the medication and the medication hasn't worked, and you've tried injection, the injection didn't work. Like, if you're just living in that world of those are the only options, I could see how you would get there. But from our perspective here at Novera, like we see so much impact if we can just get the upper part of the neck moving. So that would be the negative side of those fusions, which again, there are scenarios where it's warranted or helpful. And then the injections as well. So if there's a segment of your neck that is just inflamed, irritated, it's generally going to be the neck itself that's hurting. So if it's like C4-5, the mid or sort of, the mid portion of your neck will present with pain. If you're getting headaches, I would shy away from going down this road of getting injections into the mid portion of your neck again, because the headache pain itself is likely coming from up higher. And then in a separate kind of a side conversation is when we erase or eliminate or take away the body's ability to tell us that something's wrong, then we sort of are masking the problem and allowing our bodies to move in a way that it wouldn't move if the pain was there. So meaning if you turn your head and the pain increases at a certain range of motion, and we take that away, and then you can turn your head all the way, well, it doesn't mean that the stress isn't there anymore. It just means you shut the pain signal off. And so injections of steroids into the neck, I would try to avoid those as much as possible. There are scenarios where they may be helpful, or at least for like a diagnostic purpose, but I've actually seen them increase patient's symptoms, and then we kind of have to work with them to get them back to where they were. So the medication process leading to injections and the potential surgery, we need alternatives. It's kind of a broken process, a broken system, and you, the patient out there, You, the person with headaches or migraines, you know that. And so that's why you find this podcast and you have so much hope, because we can just talk about things that are different, that are outside of that. And then if we've done those things, if we've tried the conservative things and we've gone through that process, and by the way, it should work. It's a very high percentage of people that it works for, unless there's different scenarios where if it's just the neck has been in this scenario so long that, and there's different signs and symptoms. And by the way, we have people that, most of the patients we work with have had decades worth of symptoms in this neck problem. So I'm not saying like if you're, in your 50s and you've been dealing with this since you were a teenager that there's like no hope or anything. No, the opposite. I'm saying that there's a lot of hope, and it's rare that we find someone that we can't help. But it's always important to take action as soon as we can, because we don't want to just wait and let these symptoms continue, because there are worse scenarios out there. And these are the interventions that will be there for those worst scenarios, as opposed to just treating it conservatively. All right. So I hope from this podcast, you all have a better understanding of how our healthcare system views the headache and migraine diagnosis and clumping the neck into that, how they evaluate the neck, and how that would lead to the prescribing injections or potential surgery, and then how we should think about those procedures. All right. So if you're listening to this and you've been told you need surgery, I would encourage you to reach out to us so that we can help you with your own personal story. If nothing else, I hope this empowers you to then ask questions, maybe make a more educated decision. And then if you've had this surgery in the past, if you've had a fusion, if you've had the injections, that's okay too, because the neck's always going to benefit from us getting that motion in the upper part of the neck. So someone who has a fusion in C4-5 or C5-6, we can still get motion through C1 and C2, and your neck can feel better, your headaches can reduce, all of that good stuff, that benefit can still be there. Hey guys, thank you so much for listening to the Headache Doctor podcast. I love doing this. I actually, it's kind of crazy. My wife, we had our third kid a couple days ago, and it's nap time right now, so I thought I'd swing into the office and record a podcast. But I love doing this stuff so much, and I appreciate it because you guys allow this to happen. You allow Novera to be a thing, and this podcast to be a thing. And the best way that you can continue to help us do that is by sharing this. So whether it's subscribing to the podcast, subscribing on YouTube, telling a friend or family member about it, and then, of course, reaching out to us if we can help you. Thanks so much for listening to the Headache Doctor podcast, where, as always, it's our mission to educate and empower everyone with headaches and migraines so you can break free from a life of fear of your next headache or migraine and dependence on medication. I'll see you next time.